Hello, everyone, and welcome to our module on hypertension. As many of you probably know, the term hypertension refers to elevated blood pressure. And so before we can talk about elevated blood pressure, we have to talk about what a normal blood pressure is. And so generally, most people agree that a normal blood pressure is a systolic less than 120 and a diastolic less than 80. And we define stage 1 of hypertension, the earliest stages of hypertension, as a systolic blood pressure in the range of 130 to 139 and a diastolic in the range of 80 to 89. And this is based on the most recent guidelines of the American College of Cardiology and the American Heart Association. And importantly, in order to make a diagnosis of hypertension, you need more than one measurement. And this is because in all of us, our blood pressure goes up and down, and some people can have a transiently elevated blood pressure, but it won't be elevated on a second measurement, and that means they don't truly have hypertension. To have hypertension, you have to have a persistently elevated blood pressure throughout the day. And then also, you should be aware that when you're making a diagnosis of hypertension, the patient needs to have an absence of acute illness. So if someone's in the emergency room and they just broke their leg and they're in excruciating pain, they're going to have high blood pressure from pain and activation of the sympathetic nervous system. That doesn't make the definition of hypertension. You need to measure the blood pressure when they're out of an acute illness, usually in a calm setting in the clinic. So what is the etiology of hypertension? Well, for most patients, about 90%, the cause of their hypertension is said to be primary. It's also called essential hypertension. And what this basically means is the exact cause for these patients is not clear. We don't really understand what causes primary hypertension. It's probably multifactorial and related to genetics and diet and environmental factors. For the remaining about 10% or so of patients, their hypertension is secondary to some other problem in their body. And I talk about all the different conditions in the human body that lead to secondary hypertension in another video. Some of the important risk factors for hypertension are listed on this slide. Family history is important, and so is high salt or high sodium intake. And I'll talk about why high sodium intake leads to hypertension in just a minute. Heavy regular alcohol use commonly leads to hypertension, and this is probably not going to be on step 1 of your boards. But in clinical practice, when someone has resistant hypertension, you always want to ask how much alcohol they're consuming, because if they stop drinking alcohol, often their blood pressure comes down. And then finally, obesity and physical inactivity are also associated with hypertension. So to understand why a high sodium diet or a high salt diet leads to hypertension, let's think through the physiology of what happens when you consume a high salt meal, like this meal of potato chips and French fries shown on the slide here. So anytime you consume lots of sodium, that's going to raise the plasma osmolarity in the body. And I talk in detail about plasma osmolarity in videos in the renal section. Well, in response to the increased plasma osmolarity, your pituitary gland is going to release antidiuretic hormone. And that's going to trigger the kidneys to retain water. And that's a very good thing because this water balances out the increase in sodium intake and maintains a normal plasma sodium level of about 140, which is very important for normal functioning of the body. But you pay a price for this extra water that the body's holding on to, in that the effective circulating volume goes up and the cardiac output goes up, and both of these things raise the blood pressure. So if you're constantly eating lots of sodium in your diet, then you're going to constantly have a high blood pressure because your body is always holding on to this extra water to balance out the sodium you're taking in your diet. So hypertension is usually asymptomatic. The reason it's bad is because it's associated with a number of serious pathologic conditions, and I've listed some of the important ones here. So the higher your blood pressure, the higher your risk for stroke and also many forms of heart disease, including myocardial infarction and heart failure. People with high blood pressure are more likely to develop renal failure, also aortic aneurysms and aortic dissection. There's more AFib in people with high blood pressure, and people with high blood pressure can also develop retinopathy and potentially blindness if their blood pressure is very high for a long period of time. Okay, let's talk about the effects of hypertension on blood vessels. And in order to do that, we first have to define a couple of terms. So the term arteriosclerosis literally means hardening of the arteries. You may have seen in some of your cadavers in the anatomy lab that their arteries are very hard and stiff and sometimes even crunchy. That's arteriosclerosis. One of the causes of arteriosclerosis is atherosclerosis, which I talk about in another video. This refers to lipid and fibrous plaques that build up on the walls of blood vessels. But there are other causes of arteriosclerosis besides atherosclerosis. There are other things that can thicken the artery wall besides lipid plaques. And some of these things develop in response to chronic hypertension, and so we'll talk about those now. So one of the effects of hypertension on blood vessels is called hyaline arteriosclerosis. This refers to thickening of small arteries, and it gets its name because there's an accumulation of hyaline in the walls of blood vessels. This is a picture of a blood vessel with hyaline arteriosclerosis. You can see all this pink material here. That's an accumulation of hyaline in the blood vessel wall. And you can see this in patients who have chronically elevated blood pressure. You also can see it in patients as they age. It's also common with diabetes. And this is one of the mechanisms by which hypertension damages organs. It causes this thickening of the blood vessel walls, and the lumen can get very narrow, and that can lead to ischemia of various organs. Another effect that hypertension can have on blood vessels is called hyperplastic arteriosclerosis. When this happens, the arteries start to look like an onion skin. This is a picture of a blood vessel with hyperplastic arteriosclerosis on the screen here. Hopefully you can appreciate these layers like an onion skin in the wall of the blood vessel. You can also see that the lumen has become very, very narrow. And this type of arteriosclerosis only occurs when hypertension is very severe. Usually the diastolic pressure has to be over 120. And this is the kind of thing you see in so-called malignant forms of hypertension, which I'll talk about later in this video, but these are severe forms of hypertension with very, very high pressures. When hypertension causes blood vessels to become stiff, that can lead to an increase in pulse pressure, and this is a high-yield thing to know for step 1. So to understand this, consider that a normal blood pressure of 120 over 80 gives you a pulse pressure of 40. That's the difference between these two numbers. In a person with hypertension, you could see a blood pressure of 170 over 100. Not only are both the systolic and diastolic pressures high, but the pulse pressure, the difference between these two numbers, is also high. And this happens because when you have stiff arteries from hypertension, that leads to decreased compliance in the arteries, and that makes the pulse pressure go up. So to understand this, let's imagine we have a very healthy, distensible vessel here. It's got a very high compliance. And so when you force blood into this vessel, the walls are a little bit stretchy. And so they sort of stretch out and they absorb some of that force. And as a result, you get a smaller pulse pressure. Now imagine you have a very stiff vessel from chronic hypertension. When you shove blood into this, the walls aren't stretchy at all. They can't distend. So the force from the blood going into it really pushes against the walls, and that drives up the pressure. This not only causes high blood pressure, but it causes a high pulse pressure as well. Another way to think of this, if you like physics and math, is that compliance is defined as the change in volume divided by the change in pressure. Well, if we rearrange this equation, the change in pressure equals the change in volume over the compliance. So if we put a given volume of blood into a blood vessel, but the compliance is very low because of hypertension, then what's going to happen is this pressure change is going to go up, and the delta P is the pulse pressure. So if you like math, which I do, but not everybody does, then by this equation here, you can see that anytime you give a standard volume of blood to a vessel that has a low compliance, you're going to get a higher delta P, meaning a higher pulse pressure. Another effect of chronic hypertension on blood vessels is called arteriolar rarefaction. The term rarefaction means a decrease in density. And so basically what happens in arteriolar rarefaction is you lose arterioles and capillaries because of chronically elevated blood pressure. What's happening essentially is that the arterioles are closing off and then getting resorbed. So remember that when the wall of the blood vessel, the arteriole, gets thicker and thicker, the lumen gets smaller and smaller, and eventually you can have essentially no blood flow going through the arteriole. When that happens, the arterioles will just close off and get resorbed, and the same thing will happen to capillaries. And so you can see this in tissue beds of patients who have chronically elevated high blood pressure. These patients will have lower density of arterioles and capillaries, and that's called arteriolar rarefaction. Hypertension also has important effects on the heart. It's super high yield to appreciate that when the blood pressure goes up, the afterload on the heart is increased. This is going to decrease the cardiac output, and it's one reason why patients with chronically elevated blood pressure can develop heart failure. You should also be aware that when there's chronic hypertension, the left ventricle is going to adapt to that stress by undergoing concentric hypertrophy, which I talk about in more detail in other videos. But you're basically going to get very thick walls of the left ventricle because the left ventricle is working harder and harder to pump blood out against that high blood pressure. And you can see evidence of left ventricular hypertrophy on the EKG. If you look at the bottom left side of the screen here, this is a normal EKG, and this is an example of left ventricular hypertrophy. Let's look at V4 to start. So notice that the QRS complex in V4 spans this distance here, which is about a box and a half of size. Now, if we look at V4 over here from top to bottom, it's spanning 4 or 5 boxes. That's left ventricular hypertrophy. There are specific criteria that define left ventricular hypertrophy. You don't have to know these for step 1, but the big picture idea is that these QRS complexes get bigger when the left ventricle undergoes hypertrophy. Also, when the left ventricle undergoes hypertrophy, you can feel a displaced apical impulse when you feel for the apical impulse on the patient's chest with your hand. And then also you can get a fourth heart sound in S4 when there's concentric hypertrophy. And I talk about this in the video on heart sounds. In clinical medicine, we use a term called hypertensive urgency. And what we mean by this is a patient who has severe hypertension, but no evidence of end organ damage. And I'll talk about what end organ damage is in a minute, but it's basically dysfunction of organs in the body because of high blood pressure. So in hypertensive urgency, the blood pressure is very high, but there's no evidence of organ damage. There's no definite agreed upon blood pressure value that defines hypertensive urgency, but most people say it's over 180, over 120. When the blood pressure gets this high, patients sometimes need urgent treatment to try and bring that down. So if you understand that, then it's easy to understand what a hypertensive emergency is. This refers to severe hypertension with evidence of organ damage. Just like hypertensive urgency, there's no definite value, but most people agree that the blood pressure has to be over 180, over 120. This usually happens in patients who have long-standing hypertension and abruptly stop their meds. Their blood pressure can get very high and they can start to get symptoms from that. So what are some of the symptoms that can occur from high blood pressure? We call these symptoms of end organ involvement. So in the brain, you can have things like retinal hemorrhages that you can see on physical exam. The patient can also develop confusion from encephalopathy. In the kidneys, acutely elevated blood pressure can lead to acute renal failure, and patients can have hematuria and proteinuria on urinalysis. And then finally, if the blood pressure is severely elevated, patients can develop cardiac ischemia. Once again, this is related to very high afterload and very high work of the heart, and the blood vessels can't deliver enough oxygen to meet the demands of the myocardium. In videos in the hematology section, I talk about MAHA, which is a rare form of anemia called microangiopathic hemolytic anemia. And this can sometimes happen in the setting of a hypertensive emergency because if the blood pressure gets very high, then it can damage the endothelium, and that can be a nidus for thrombus formation, and thrombus formation is what leads to the anemia of MAHA. So these patients can have a low hematocrit in the setting of severely elevated blood pressure, and the hematocrit often gets better with blood pressure control if you bring down the hypertension. And then I'll finish this video with one slide on the term malignant hypertension. So in the modern era, when people say malignant hypertension, they basically mean hypertensive urgency. But the original term malignant hypertension was a historical term when doctors first started realizing that high blood pressure was bad. For a long time, people actually thought high blood pressure was good because it helped to perfuse the organs. But once they began to realize that high blood pressure was bad, they saw that most cases of hypertension were benign. These patients had modestly elevated blood pressure that was stable over years. But there was a subset of patients who presented with what was called malignant hypertension. This was a rare form that was often fatal. So they would, shortly after diagnosis of hypertension, develop severe elevation of blood pressure, like a diastolic over 120. And over the next year or two, it would rapidly progress, and they would develop renal failure and eye problems and cardiac ischemia. And so this form of hypertension was called malignant hypertension to distinguish it from the benign. But as I said, in the modern era, when you hear someone say malignant hypertension, they usually just mean hypertensive emergency. And that concludes our video on hypertension.